Today, Mark Bounthavong is here to talk with us about his work in the VA and his work with academic detailing. Dr. Bounthavong has his bachelor's degree from UC Irvine. He has a PharmD from Western University of the Health Sciences. He did a PGY1 residency at the VA in pharmacy practice. He then did a pharmacoeconomics and outcomes research fellowship at the VA, became a pharmacoeconomist within the VA, has an MPH from Emory. There is an Emory alum in the house, two of them actually now, and has his PhD from the University of Washington, which he just finished when? In July. And will be working now within the VA health system at HERC, right? The Health Economic Resource Center?
That's right.
Yeah. I'm trying. So Mark's going to talk to us about the work he's done with academic detailing and naloxone prescriptions within the VA. Thank you, Mark.
Thanks for inviting me. I think the timing worked out really well. I was actually in town for the VA medical advisory panel and visited pharmacy executive meeting, talked about my research there. But just to let all the students in the room know that it is possible to graduate with your PhD. It might take some time, but just you have to endure. Sometimes it's 5 years, sometimes it's 10, but somewhere between 5 and 10 you'll graduate. All right. So as Todd generously introduced me, I did finish my PhD recently in July, and it was primarily based on two aims. But what I'm going to do today is talk about the first aim, and the first aim is really the aim that I really wanted to do at the VA. So when I came into the VA, I worked as a pharmacoeconomist, and a lot of the work I initially did was looking at pharmacist-run clinics and evaluating their effectiveness and value. Then when I went to the University of Washington, I kind of wanted to continue that mission. So I connected with the director of the Academic Detailing Program Office at the VA, who's Melissa Christopher, and she said, we would love to have someone in-house do our own evaluations, because they used to coordinate with HSR&D, which is the Health Services Research and Development Group, to do their evaluations. But a lot of times, those type of partnerships are really hard to come by. One, the funding issue is always not very transparent, and two, priorities always change. So they hired me on in 2016 to evaluate their program. This is the genesis of my dissertation project. So let's see, make sure I got everything in order. All right, so my obligatory disclaimers and disclosures. I'm a government employee. Therefore, anything I say or do does not reflect the opinions of the VA or the federal government. In fact, if I make any mistake, the federal government will probably disavow me. But if I make any great contribution, they'll take all the credit for it. So there's no such thing as IP in the government. So just briefly, I'm going to talk about some background regarding the opioid crisis in the United States, especially in regards to naloxone distribution. Then I'm going to present my one aim, which is looking at the effectiveness of the academic detailing program. In regards to implementation strength, I'll talk about the approach I use, and I'll make some commentary about other approaches we thought about but we ruled out. Then I'll conclude with some results, and then I'll take any questions at the end. So I'm sure you're familiar with the opioid crisis. It's an epidemic of great proportion that we haven't seen since HIV came in the early 80s, and even with hepatitis. This is something that's been increasing over time, and just recently we started to see a downward trend in the opioid overdose rate for 2018. However, that data hasn't been released yet. But in rough numbers, we have over 100 people dying every day from opioid-related overdose, and this is synthetic and non-synthetic opioids. And when you think about the numbers, it's about greater than 40,000 a year die from an opioid overdose. When you compare that to motor vehicle accidents, in 2016, that number started to exceed motor vehicle accidents in the United States. So we see this crisis happening. We see that it's getting worse over time, and we expect some kind of response from the federal government. So initially, the federal government came up with three major prongs of attack or strategy. One is to improve opioid prescribing practices, and this is really to sit down with experts in the field and reform how we manage pain in the United States. When I went to pharmacy school like decades ago, I remember being told that there was no ceiling dose on morphine. that pain was to vital signs. You had to treat it. You had to get it to zero. So everyone was giving opioids in order to get the pain level to zero. And there's a lot of weird incentives that go on with that. Patient satisfaction scores based on providers giving them opioids to take care of their pain. If you take away the opioids, satisfaction scores go down. So providers are incentivized not only to take care of the pain, but also to deal with these weird metrics that they were being enforced. So the CDC, the VA, the DoD got together and they reformed these guidelines. So in 2016, new guidelines came out regarding pain management. So that's the first thing the federal government did. And the other thing was to expand access to medication-assisted treatment for opioid use disorder. And if I had to be a critic, this is something that we've done a very poor job at. At the VA, we have a lot of providers that are credentialed, ex-waivered, to give MAT therapy to OUD patients. The problem is we have a lot of providers who are credentialed but have 0 patients on MAT therapy. So what's going on? So that's an issue that we have to eventually address at the VA. And one of our next projects in the next fiscal year is to look at this more carefully. But what I'm going to talk about today is about naloxone distribution. Because one, it's the low-hanging fruit. Naloxone is available at the VA. It's available everywhere. It works very, very well. The problem is we didn't see a lot of it being prescribed in 2014. So this is where the story of my dissertation really begins. Around 2014, when the VA started looking at this more carefully and realizing, wow, we haven't really done anything with naloxone, and this is really easy to create access to. So just a brief overview of what naloxone is. It's categorized as an opioid antagonist, and what that really does, it competes with opioid at the mood receptors, and it displaces it. And when the opioid connects to the mood receptors, it leads to side effects. Severe side effects are life-threatening, in particular respiratory depression. So what naloxone does, it just basically kicks it off, and it kicks it off very, very fast. So you can get a response from the patient that's overdosing within minutes. And they'll stand up and they'll be alert and lucid. And it's an amazing thing to see that. The problem is they need to have access to the naloxone. The other thing is you have to have someone administer it. So there's a couple of barriers to that. And the VA tried its best to see if we can reduce some of those barriers so that way patients can have access to this life-saving medication. So my friend wanted me to talk about this slide in a little more detail. He says he always tells me naloxone is great, but what's the problem? One, it's a break in the prescribing practice of providers. If you're a primary care provider, when you see your patient usually has chronic diseases, diabetes, hypertension, hypercholesterolemia, and you're treating these chronic diseases with medication. With naloxone, it's a little bit different. It's not a curative in the sense that it cures a disease, but it's more like a preventative medication. You give someone naloxone anticipating an opioid overdose, and providers are not really used to that. There's a few cases where you can give something like glucose tablets for a patient that's going to have hypoglycemia, and they prepare for that. They're more comfortable with that. But in 2014, providers at the VA weren't really comfortable just giving naloxone willy-nilly to a patient that had an opioid on their profile. So this is really a break in their prescribing pattern. This is where academic detailing is really going to be helpful in order to augment that behavior, so that way they can be more receptive to the idea of giving naloxone to patients who are at risk of an opioid overdose. Now these pictures really illustrate how the VA evolved over the years. So in the picture on the left was our first naloxone kit that we dispensed to patients. And this was before the FDA approved the auto-injector and intranasal device. We would give a syringe with a vial, educate the patient to draw it up themselves, or have someone in their family do it, or friends, and then we give them an atomizer. But as you can imagine, during an emergency, all kinds of things can happen. They either poke themselves with a needle, they don't draw it up sufficiently, they forget to put the atomizer on, they shoot it up into the nostrils. So all these things can happen with the kit. So when these agents came out, the VA put them on formulary. So I want to talk about the VA's policy surrounding naloxone. So prior to 2014, we didn't have a distribution program. In fact, we couldn't even order this for the outpatient to be dispensed. Providers had to come up with really creative ways to use the electronic record system to write for naloxone for their patients that they thought would be at risk. So the VA took the initiative to create a more formal order entry system in our electronic health record system so that way providers can actually write naloxone for the outpatient setting. But in 2014, as you can imagine, we didn't have any FDA-approved products that was not vial. So that's why we had the kits. The VA Pharmacy Benefits Management also took it upon themselves to create a program where all facilities would not pay for naloxone. So within the VA, how the budget works is that each pharmacy department and every site had a budget of how much they can purchase with that money. And that budget usually would have to include naloxone for outpatient administration. But the PBM's consolidated mail order pharmacy said we're going to take care of it. Each site won't have to worry about this. So the economic burden was removed. That was what the PBM did. The other thing was we added it to the formulary, so we made it available through the electronic order system. So when you type in naloxone in the EHR, it would just pop up with the kit available for outpatient administration. But probably the most significant thing the VA did was implement the opioid overdose education and naloxone distribution program. This is a program that was generated from the, I believe it was from the Mental Health Initiative, but in collaboration with the Substance Use Disorder Group. And what they were trying to do was make sure that every provider, every patient, their caregiver understood everything about naloxone prevention, naloxone and opioid overdose prevention, recognition, and response. The challenge with OEND was they only had a few people, and the reliance on other sites to implement this themselves was not always reliable. So they partnered with the Academic Detailing Service to be the foil to interface with the provider in the networks in order to deliver the OEND key messages, such as naloxone administration, distribution, and also how to teach it to their caregivers. So this partnership is really important. And when I came on board the VA to look at this program, I immediately realized that we have to understand this interaction between OEND and also academic detailing. Now, prior to this, the academic detailing service was just getting off the ground. Academic detailing really focused on mental health issues such as schizophrenia and insomnia. So having them go into this space with naloxone distribution was sort of new for them. So in 2014, they had to reorganize how they were going to do this. And this is why that partnership with the OEND program was really important and critical. So to this very day, we still have this partnership and we interact very well together. In fact, we submitted several grants to look at this effect over time, and hopefully those things get funded. So for those of you in the audience that are not familiar with academic detailing, think of a drug rep coming in to try to sell you a product if you're a provider and get you to write that medication for your patients. There's a certain bias to that, in that the drug rep wants you to write for their medication to your market. Academic detailing takes those same skill sets, but rather than bias the provider, we provide unbiased evidence that's synthesized for them. We provide educational outreach to providers with the sole purpose of aligning their prescribing behavior with evidence-based practice. That's the key difference between academic detailing and some of the stuff you hear about with drug reps and their strategy. So there's a lot of different frameworks we could apply to academic detailing, such as the social marketing framework, which is where a lot of the drug reps have generated their strategy from. Jerry Avorn and Stephen Salmarai from Harvard were the ones who really coined the term academic detailing. And I saw Jerry the other day, and Todd was there. And we talked about this with Jerry, and the reason why he chose academic detailing as the phrase, because he didn't want it to be confused with what the drug reps were doing. This is an academic, unbiased presentation of synthesized evidence in order to align the providers with evidence-based practice. So that was the key. Now, when I first came to the VA in the academic detailing program office, my boss, Melissa, who's really motivated to push this program out, implemented this in 2014. And they really didn't have a strategy for how to evaluate the program. If you work at the VA, as long as I did, or have, you'll realize that when someone at the top makes a decision to implement something, everyone has to do it. And you have this haphazard implementation that goes on. Some places are doing it, some places aren't. Some places are doing it wrong. Some places are doing it right. Some places are kind of doing it somewhat right, somewhat wrong. So it's just this mess. Implementation is just a mess at the VA. And when I came on board, she asked me, can you evaluate this program? And I remember thinking, I hope we have data. Because when you look at the electronic health health record system, it's patient-oriented. It's not provider-oriented. All the medical records is patient records. We don't have provider records. How do we capture an academic detailing intervention with a provider with the current EHR system? The answer is you can't, because it's designed for patients only. So what the academic detailing program office did was they actually created their own system using Salesforce. It's a cloud-based platform. How many people have heard of Salesforce.com? Okay. Now, what's remarkable about Salesforce is this is what the drug reps use. So we took a page from their playbook, and we created our own version of Salesforce where our academic detailers would go out to providers and document their visits. And that's how I was able to get the data. So I was able to interface that data with the corporate data warehouse of the VA and monitor providers that received academic detailing and providers that didn't receive academic detailing, and looked at their naloxone prescribing rates over time. And this is what you see here. The blue line represents providers that got academic detailing. The red line represents providers that did not get academic detailing. And we looked at over 24 months since the program started, and we saw that providers had a much greater acceleration in terms of naloxone prescribing versus providers that didn't. They both increased naloxone prescribing, but that's mostly due to temporal effects or secular effects across time. The treatment effect difference is really where you see that acceleration with the blue line. So this is the first project I did. And from this project, we started thinking about, okay, what are some issues with this analysis? Well, one, selection bias is an issue. Maybe academic detailers are selecting providers who are going to write for more naloxone. The other issue is implementation heterogeneity. As I mentioned earlier, in the government, when we implement something, it's just this haphazard, random mess that we just create in a race to try to get this program off the ground. So one thing that I was interested in was seeing what is the effect of implementation heterogeneity on naloxone distribution at the VA. So I initially looked at provider level effects, which is that figure I just showed earlier. Now I wanted to look at station level effects. How was implementation done at each station? How was the implementation strength or intensity related to naloxone prescribing at each station? So here's an example of two random stations I picked. I'll call them Station A and Station B. And the y-axis represents the proportion of providers at that station that received an OE&D-related academic detailing, educational outreach visit. Now, Station A received academic detailing early in the calendar year, and they had a sharp increase in the number of providers that got exposed to academic detailing, and it slowly plateaued out. Station B, on the other hand, had academic detailing implemented much, much later in the calendar year, and their intensity was not as strong as at Station B. Now, if you can imagine, the VA has approximately 130 stations in the country. So when I looked at this, it was basically a giant mess of lines that had some high intensity, early implementation, or low intensity, late implementation, or even no implementation at all. So this is the problem with implementation heterogeneity. How is this affecting naloxone distribution in the VA? So the aim I came up with was I wanted to evaluate this implementation problem with naloxone prescribing at the VA. And for me to do that, we had to be really creative with our design. And I'll talk about other designs we thought about, but we had to rule out. But if you're going to write a paper, these are the kind of things you want to put in there. The retrospective study design. The setting is VA National. Whenever you have VA National, people get excited because then you have like thousands of people. We're going to look at the station level, which is different from the previous study I did where I looked at the provider level. So we're going to look at the station level. And the reason why we did that is because we're going to cluster on the station. This is kind of cool because when you start clustering on stations, you can do a lot of cool things with that. The outcome will still be a number of naloxone prescription prescribed, but instead of the provider level, we're going to look at the station level. And we're going to look at the proportion of providers that were exposed to an OE&D-related academic detailing outreach visit as our predictor of interest. And we're going to look at from September 2014 all the way to December 2017. Now, with station-level analyses, we had a couple of hierarchies we had to think about. So at the station level, I got the data about the station from the corporate data warehouse. And this is information about number of patients that the station treated, the number of outpatient visits they had, the number of inpatient visits they had, ED visits, prescriptions prescribed. There are about 130 stations. And we looked at a closed cohort of providers. And we looked at the providers at each station. And the reason why we did this is because the VA can get new providers and providers can leave the VA during the study period. And that can introduce some bias So what we did was we looked at a closed cohort of providers from beginning to end. So that way our denominator is pretty much stable. So this is important for us to do. Now, information about the providers, their background, their gender, their age, their tenure at the VA, we got from the corporate data warehouse. And the interaction with the academic detail we captured using Salesforce dashboard. And of course, we had to look at the patients because the outcome was number of naloxone prescribed. So we had to look at patients that were at risk for an opioid overdose. So that meant a patient in the study period within that provider cohort that received an opioid prescription. And we were able to get this from the pharmacy claims data in the CDW. So for our analysis plan, and this is where I want to talk about some plans we thought about, we ended up using a fixed effects negative binomial model. We thought about Poisson because it's account data, right? But we looked at the dispersion. Apparently, the over dispersion parameter showed us that Poisson wouldn't be a good fit. So we dropped that using negative binomial. When I first started this dissertation idea, we looked at regression discontinuity design. Are many familiar with the RDD, regression discontinuity design? It's a really cool design. The problem is you have to have a good identifier or running variable. And I remember when I first started this project, one of my committee members, Von Boss, said, you need to do an RDD, Mark. It's really good quasi-experimental design. People are going to love it. We don't really see it in health services research very much because a lot of the data just isn't there. So I spent about 6 months looking for this elusive running variable, and I couldn't find it. It took me about 6 months to rule that out. So when I talked to Honorable, he said, okay, sorry, you wasted 6 months, but you learned something. So I asked them, okay, so I came up with a couple other alternatives, instrumental variable, but of course, if the running variable isn't working, then the instrumental variable won't work either. We ended up throwing that out the trash. Then I actually introduced the idea of maybe interrupted time series analysis would be good, but then he said he ruled that out too because you really want to preserve that calendar time. And when you do an ITS and you index everything based on the exposure, you lose that. So we ended up going with a fixed effects design because I was in his class when he said these really cool things about fixed effects model. If everything works in a fixed effects model, you can make causal interpretation. Really powerful. So is everyone familiar with a fixed effects model? Kinda? It's not the same fixed effects model you see in meta-analysis. That's different. So in fixed effects model, you think about endogeneity and unobserved heterogeneity. And what does that mean? This is economic slang. So you have variables that are they're constant across time with each station at the individual level. And these non-constant variables may be systematically different from one station to the next, right? Like maybe one station has more academic detailers and another station has less academic detailers, but they're systematically different. But this is something that's constant over time. It doesn't really change. So in the fixed effects model, you're not concerned about these systematic differences because all you're concerned about is the change in the outcome across time. If everything stays the same across time, then you can subtract that systematic difference out. And that's the power of a fixed effects model. Okay, so you gotta think about what are these systematic, non-time varying predictors that I can subtract out of the model. The important thing about fixed effects model is you have to think of what are the time varying predictors. What's changing across time at each station? You have to control for those. That's something we have to think about when we're looking at this analysis. So when I say station level time varying covariates, we thought about what makes a station unique from each other. Well, the number of outpatient visits change across time. So does the emergency and urgent care visits, the inpatient visits, and we also looked at the prescription fills of each station across time. So in our fixed effects model, we included the time invariant covariates, but when you run the regression, you expect that to zero out. And the only thing that really should remain are the time varying covariates. Does anyone have any questions? That's always hard for me to explain, but you have to believe me that this actually works.
Mark was speaking to the last related policy. Was it introduced all at the same time across all the stations?
The OEND program was that's a good question. So let me just rephrase that. Was the naloxone policy implemented at the same time across all stations at the VA? Yes, it was. When you if I interpret implementation as an announcement by email to facility directors, that happened. But when it came to actually implementing the program, having someone there to do internal facilitation, having someone there doing external facilitation, that varies across the system. So that's something that is also systematically different. Yeah, that's why this continuity didn't work. So let's kind of give you sort of like a breakdown of my model. I have the predictor of interest, which is the portion of providers exposed to academic detailing. I have month as a continuous variable. Then I had time as a fixed effects component of my model. So I'm fixing time here for each station. And I also have a station fixed effects model. So this, as I mentioned earlier, you want to maintain the time constant variables within each station, similar with time. And the reason why you do that is because you want to address the shocks you see across time. Then I have the number of eligible patients also changed. So this is the offset term in a count model. So when you do Poisson model, the negative binomial model, it's very easy to forget the offset, because a lot of times everything is individually spaced. But in this situation, we know that the number of patients across time that are going to be exposed to an opioid is going to decrease. And the reason why is because the prescribing patterns have changed over the years. VA providers are aware now that opioids are dangerous. They're going to try to discontinue or taper their patients off opioids. So that number is going to change. So we had that as an offset term. And we also had time-varying covariates, as I mentioned earlier. And of course, our outcome is number of naloxone prescribed per station. And the time interval was month. So these are my results for the provider cohort. We had about 5,400 providers, about 54, 55 years old. Majority of them were female. Majority of them were primary care. These are all primary care providers, but we had a distribution of physicians, physician assistant, nurse practitioners, and some mental health providers are also coded as primary care providers. We looked at the average number of providers that was exposed to academic detailing visit across time, and we had a range between 0 and 94% on average. And we also were concerned about, okay, how does the distribution break up when it comes to some of the baseline characteristics of these stations? So I also broke it up into proportion of providers exposed at each station at different strata. So I have 5 stratas that I looked at. And we saw that there are really no differences in some of the characteristics there. So that really was convincing that we didn't see much selection bias across these different strata. Now, when it comes to just the descriptive analysis, we saw that naloxone prescribing was increasing across time. We expected that because of the relative accessibility of naloxone being available. But we also see that the proportion or the number of patients that were eligible to receive naloxone also decreased across time. This is why we had that offset. And when I broke down my stations into stations that received, that were exposed to academic detailing, and stations that were not exposed to academic detailing, you can see the cumulative number of naloxone prescription was much greater with facilities that actually implemented academic detailing versus facilities that did not. And when we ran the regression model, the IRR, or the incident rate ratio, for a station, a hypothetical station that had 100% of the providers exposed to academic detailing, was 5.5 times higher than a station with 0% of academic detailers, 0% of providers exposed to academic detailing. Now, when we did the marginal effects, I don't have the slides for this, but when we did the marginal effects, what does that translate to a number of prescriptions a month per station? Well, this translates to about 9 prescriptions a month increase in the stations that have academic detailing versus stations that doesn't have it. And this is huge because an average station at the VA, and I don't have this data, but I can tell you this, it's about 2 to 10 prescriptions on naloxone, maybe 15 on average per month. So when you think about a station that implements academic detailing fully, 100%, you're getting about 9 prescriptions extra on top of that. That's an incremental increase of 9. It's huge. So for the VA, this is sort of like an opportunity cost for us. We have an opportunity to increase our exposure to academic detailing, and because we're not doing it, we lost this potential benefit that patients can get access to naloxone. So of course, with every design, there's always limitations, and I have to be quite honest with you. implementation intensity or strength is just one element of implementation. There's implementation quality, there's fidelity, and adaptation. And of course, when you look at academic detailing with a microscope, you'll find that every station implemented academic detailing differently. So some stations would have what we call a consolidated work unit. And a consolidated work unit at the VA represents sort of like how an academic detailer gets paid. So when you think about it intuitively, a pharmacist who's an academic detailer that has 100% of their time dedicated to academic detailing might be more efficient than a pharmacist that only has 25% of their time dedicated to academic detailing. So some stations had a consolidated work unit where 100% of the pharmacist's time was dedicated to academic detailing. And some stations had another work unit that didn't have that sort of dedicated time for academic detailing. And they have to compete with their clinical duties and the academic detailing duties. And the consensus is that there's going to be a difference in the sort of adaptation of the program because of that hierarchy of how they pay their academic detailers. And there might even be an effect on the quality of the academic detailing delivery. But we don't have that data, so I can't assess that. And also the fidelity of the program. Did they do academic detailing or implement academic detailing the way it was supposed to be implemented in terms of full implementation? In our definition of full implementation was 3 full-time FTEs at each visit, performing approximately 22 to 30 visits, I believe it was a week. So did they do that? These are questions that we really haven't got the information on, and this is some of the limitations of implementation metrics. I only focus on implementation strength and intensity, but you can imagine there's implementation quality, which includes satisfaction, where the provider is satisfied with the delivery, fidelity, and adaptation. And of course, the VA is a unique environment to perform these types of activity. It's the largest integrated healthcare system in the country. And usually when they do something, they try to do it uniformly. But as you can see, with academic detailing and OE&D, that sort of this implementation was not uniform. There's a lot of heterogeneity. Also, the characteristics of our population is different from the general U.S. population. VA patients in general have about twice the risk of a drug overdose compared to the general population. We also have more prescribing of opioids. Well, that was at least true in 2014. It's probably a lot different now because the landscape has changed. But when we first started looking at this, we realized our patients were at greater risk for opioid overdose. Now, some of the major implications is that, one, we realized quickly that sites that didn't fully implement academic detailing really were limiting access to naloxone for those patients. Providers may be prescribing it, but they may not be prescribing it convincingly for all their patients that were at risk of an opioid overdose. And of course, scale-up of a national program should probably be done with some type of implementation plan in place. So one of the lessons we learned is when we implemented this program, we tried our very best to make sure that there was a uniform implementation process going on. But one thing you realize within the VA is leadership can be a major barrier to implementation. So when I did a couple interviews or follow up on this question, and some sites told me that they couldn't get funding to allocate for an academic detailer. Hence the reason why they didn't implement academic detailing. Other sites had funding, but because their leadership wanted them to do more clinical pharmacy services as opposed to academic detailing, they really never did any academic detailing work. Now this is kind of scary because the Undersecretary of Health mandated that every VA have an academic detailer. And then the Comprehensive Addiction and Recovery Act that was signed into law in 2016 by the Obama administration also recommends that every VA, not just hospital, but the VA, implement academic detailing. And to this very day, we still have less than 100% that have implemented academic detailing. So to kind of give you an idea, when I presented my data today, this is from 2017. At 2017, we still had 27 stations out of 130 that didn't implement academic detailing. I'm hoping that number has changed today. I need to go back and look at the data again. But that kind of gives you an idea of how slow and how resistant sometimes implementation can be, especially at a national scale. Now, some future research and recommendations that I kind of gave to my boss when I finished my dissertation. One, we need to identify and develop policy to address implementation issues. And I only focused on naloxone today, but we implement academic detailing in so many different areas. Like this year, we're implementing academic detailing for suicide prevention, and we're also implementing a new program called e-detailing, where academic detailing is going to leverage telehealth technology in order to penetrate into rural areas, especially providers in rural areas that are very challenging for an academic detailer to get access to. We need to really develop implementation plans that are robust, that address some of the pre-implementation needs of a program, and then try to cater our design so that way we address those issues up front. Of course, outreach efforts such as telehealth and the VA Video Connect system is probably one mechanism to do that. But we have to think about how to cater all of our implementation plans for each of the challenges we face in the future. The Comprehensive Addiction and Recovery Act mandates that we report to Congress how we're doing. So maybe we can leverage this in order to get sites that haven't implemented academic detailing more motivated to start reporting their implementation plans. And the other question I always get but I never have an answer to is how much implementation is enough? Is it okay if we implement 50% of the time, 80% of the time, or 100% of the time? Do we have to have all our providers exposed to academic detailing in order to see all of our maximized benefits? Or can we just do 50% of the providers exposed to academic detailing and then live with that at the end? So that question is really hard to answer. In fact, we've been trying to figure out how much implementation will be needed in order to be comfortable and okay with the numbers that we have. But according to leadership, they want 100% of facilities implemented, and that's something that is always a challenge, especially when you're trying to get to the last 2% of sites that are so resistant to change. Okay. I just want to acknowledge all the people that helped me with my dissertation, and it obviously takes a village to raise the village idiot here. So when I came into the program, I knew nothing. I knew zero. This is what I knew. And now I only know this much more. But the real lesson is knowing what you don't know, but developing the skill sets in order to find out how to learn the things you don't know. So the people I've highlighted here are the people on my committee. Melissa Christopher is the director of the Academic Detailing Office, and she was the one who really pushed to get these evaluations out. And it's rare to find a program director that's so ingrained in operations work and not research, that really wants to get robust analyses out there. So she really promoted this, and this is something unusual when it comes from the operations side of things at the VA. And of course, my University of Washington committee, Dave Beanstra, who always reprimanded me whenever I try to come up with a dissertation idea without a policy behind it. So in our program, his philosophy is, if you have no policy impact, what's the point of doing your study? And Honorable Mbasu, who always, well, first of all, he made me spend 6 months of my life trying to figure out that regression discontinuity didn't work. But at least he gave me face-to-face time, which is really rare nowadays. When you're a busy guy like Honorable, it's hard to get face-to-face time with him. It's like you got to win a lottery or something. But I was lucky enough to get his time right before he got really busy, and he really was a great mentor, especially when it came down to encouraging me to look at all the different study designs that were out there, so that way I can rule out the ones that were really effective, but didn't really fit my question, and I identified the ones that did. And of course, Emily Bounthavong was my chair. She was the one who really encouraged me to continue with the work that I was doing, and Ed Kelly was my MGSR. All right. I know I left a few minutes at the end for questions, so hoping you guys will have some questions for me.
Mark, I have at least one question that I'll start with. So the actual academic detailing itself, how consistent was that within stations and across stations? So did detailers use the same kinds of tools when they went to see providers? Was there some uniformity in what they did?
I'll repeat the question for the audience on the call. So Todd asked whether or not there's some uniformity or standardization with delivery of the key messages the academic detailers presented to providers. and I'm going to focus specifically on OE and D. So the educational tools were all standardized. The clinical dashboard, which I really didn't talk about, and that's sort of an important element of the academic detailer's tool set, is also standardized. So at least the material and the online clinical dashboard, these are all common elements that the academic detailer presented at each of their educational outreach visits. And the reason why is because, one, providers never read the educational brochures, but their patients do. And when they see their patients, this is something the patients really want. Two, the providers are always interested in seeing how they perform relative to their colleagues. So when you have a clinical dashboard showing the providers trend this way and their colleagues trend this way, they kind of give a fist pump and they say, yes, I'm actually better than the average. But when they see their trend going down or some other in a negative direction, then it raises that awareness. So this is the strange thing about academic detailing. It's an intersection of psychology, behavior, clinical sciences, and economics, behavioral economics. So when you have someone sort of like have that cognitive dissonance, they challenge themselves. And we've seen studies like this. As I mentioned earlier, I think Chris and Danny, Jason Doctor at UIC just published a study in a very similar aspect where they had providers with a patient panel that were on opioids that where someone died, a patient unfortunately died because of an opioid overdose. The chair of the department sent that provider a letter. It wasn't a reprimand, it was just a letter saying that your patient died because of an opioid overdose. And you see the trends of prescribing changes immediately. So having providers see those trends in a clinical dashboard that we present, which is something I believe was effective in terms of getting them to augment their behavior. So yeah, those are the things I could think of off the top of my head that were standardized. Of course, how they deliver the message in terms of their greetings and things like that can vary from academic detailer to academic detailer.
Did only the ones detailed get the dashboard?
Yeah. So the dashboard, that's how the academic detailers identify providers. They can look at the dashboard themselves and just rank the providers with the most patients on an opioid and target those top providers first and work down the line.
Is that how it's implemented?
That's how we expected it to be. In terms of fidelity, that's what we expected to be implemented. Another thing that I thought initially that they were doing, but I found out when I did my interview that they weren't, was looking at index scores for patients. So each patient has a calculated risk score called the Reassort score. And if you're interested in reading it, Zedler and their group actually published a couple of papers looking at VA data specifically to identify patients that were at risk of an opiate overdose within the next 6 months or so. And this index score was something you could use to sort of tell a provider, hey, your patient has a score of so-and-so. They're at 80% risk of having an overdose in the next few months. So one way an academic detailer can identify providers, how many patients they have in their panel with a risk index score above a certain threshold. But again, identifying the provider by the academic detailer varies between academic detailer and their system, how they want to interact with their providers.
The way it got implemented seems kind of random.
It is.
Not selected. And then the way you talk about, so we have 100% implementation or zero, sounds like there is selection, that there are some that are harder and some that are easier,
right,
based on some metric.
Mm-hmm.
There's some tension there on what is actually going on.
Yeah,
I mean, your data show pretty well that it, at least to the extent it was implemented, it was reasonably random or consistent.
Yeah, this is why the fixed effects model is so nice when you use it, because there might be systematic differences at the sites themselves. We don't know what these differences are, but if they're sort of like time constant differences, then the fixed effects model controls for that. So if it was some leader that was there at the VA that just didn't like academic detailing, well, the fixed effects model controls for that, as long as that person is still there. The limitation of the fixed effects model is if that person leaves the VA, and that systematic difference
in the middle,
then that kind of gets thrown out the window. But that's one of the limitations of the fixed effects model, making sure that the time invariant predictors remain constant throughout the models. Question here and then over there.
So Mark, did your committee push you towards thinking about like harder linking the exposure to academic detailing to like a harder outcome like opioid related deaths? I know like some time ago I did work with Todd at the VA and we actually had the national death index. We linked
So the question was, do we think about investigating academic detailing's impact on mortality, even ED visits, for example, some other hard outcomes besides naloxone prescribing? We definitely did. The National Death Index, we have access to that, by the way. So there's a 2-year delay, usually, because they need to vet the data. Because you don't want to have a veteran that died but really didn't die. That's happened before, especially when it comes to electronic health records at the VA. We try to vet the data. It takes about 2 years, and we get it from the CDC, and they give it to us, and it's already clean. But it takes about 2 years to get that data, and it's always a 2-year lag. So we looked up to 2017, which meant that we didn't have access to that data. But to your point, we are doing that in our next study. In fact, I have the data up to 2016, and we are investigating that right now. So we're going to look at ED visits, just overall ED visits. We're also going to look at opioid-related ED visits, and we're going to look at overall survival or overall mortality, and then opioid-related mortality. So that's in the works right now.
One thing they did do, though, that I was on some of the calls from the National Academic Center, is they did report the number of stays. But it's a patient-reported outcome, a veteran-reported outcome. But that's something that was really neat, just as an observer. Like, they continue to, almost every week, they update it, and the number of kids distributed, the number of patients saved, the number of providers detailed.
How did they capture that?
Veteran-reported.
Oh, okay.
Yeah, the comment that Katie brought up was we did report number of lives saved after post-overdose naloxone administration. So we had some surveillance going on early in the program. But when we started with our partnership with the OEND program, Dr. Elizabeth Oliva, she's the director of the program, they realized that they weren't doing a very good job of capturing that information through surveillance. So they actually closed that surveillance program down for about a year. I think it was about 9 months to 12 months. They closed it down for 12 months in order to create a national template that every VA would use, so that way they can have more standardized reporting of the naloxone sales. So now we have that program up and running again, and so we're starting to collect that data as they come in. But they are self-reported, usually from the providers when the patient comes and sees them and tells them about their experiences. So the reporting before didn't have information about who administered naloxone. That was the key we were looking for. Was it a friend, a colleague, a caregiver, a professor in your chair, or a professor in your committee? So we didn't have that information before, but now it's standardized that way. Everyone in the nation can report the exact same thing we're looking for. Thank you for bringing that up. I completely forgot about that.
Yes, you are scientific at each station, and you are comfortable making your product spill over between stations. As you mentioned, a person is like a detailing can be as a leader.
Right.
But if there are crossover between providers and patients with different PA with geographically proximity to each other.
It's a very good point. So the question was, one of the problems of the fixed effects model is if you have sort of contamination with providers leaving one facility to go to another facility. So the sort of systematic differences between the stations can be impacted, and then therefore the fixed effects model itself will fall apart. Is that about right? So that's why we had to close cohort of providers that were assigned to the stations in our study. So as I mentioned earlier, it was important for us to make sure our provider cohort was closed, so they can't leave or come into the station. So we made sure that number was fixed across time. That provider was assigned to that station. So they left. That provider was eliminated for the analysis. So we thought about that sort of geographic, sort of like migration of providers across the system.
So the National Academic Detailing Office was pretty new in 2014, right? Brand new, I think.
Yeah.
And so do you think any of the differences in your results are maybe due to the excitement around academic detailing when it was first being rolled out, because there was a ton of excitement, versus those, over time, they weren't as excited about doing the detailing visits? And do you think that any of your results are secondary to decreased excitement over time?
So the question is there sort of a shock in terms of academic detailing being introduced and having some kind of like level change immediately that may be a result of the program implementation? It's possible, and I believe there might have been. But when we included the time as a fixed effects component of the fixed effects model, we control for those shocks. So we're really just looking at, okay, naloxone change, the trend didn't change, and then we have time as a dummy variable that we sort of fix across time to address those types of shocks. So yeah, so we did anticipate things like that, but not necessarily the enthusiasm for academic detailing. So I really doubt people were actually waving a flag out there and screaming, academic detailing is the best.
First they get this first visit, and
Right.
like, oh, okay, and then they hear about like mental health prescribing from the same person, and now antibiotics. And,
Yeah.
all these different things are coming at them, and I'm like, oh, one more doctor to look at, or one more.
Yeah. So.
Where the first visit focused on opioids or naloxone, may have been
More impactful at the beginning, right? Yeah, it's funny you mentioned that because now whenever I go to meetings, especially these national meetings, and there's a problem, they always tell me academic detailing can fix this. That's the first thing they mention. I'm like, I don't think so. There's only a few of us out there, and we can't do all of this for you. But yeah, there might be some general excitement there. And again, this is where the fixed effects model is so powerful because it tries to control for those shocks in the time frame. And the good thing about the fixed effects model, it also takes care of things like introduction of new drugs, like when the naloxone intranasal came into the market, having that fixed effects for time also controls for the sudden jump in the utilization too. So we try to tease those effects out. And again, when you look at this descriptively, we really didn't see an immediate shock in naloxone prescribing. It was a nice gradual increase across time. So, but I think when you look at opioid prescribing, you might see that effect there because that seems to be something that we'll see a bigger change, especially with the high dose opioid utilization. Which if you look at 90 MEDDs or greater, 100 or 200, I think that's where you're going to see some of those initial enthusiastic effects at the beginning, because then they can target those patients quickly, and you see it in the next prescription cycle. So I think that's what we'll see. So we're going to be looking at that eventually, and I'm going to pay attention to that. So thank you for bringing that up.
Thanks, Mark, for